Happy spring, everyone. It's good to see everyone here virtually on a Friday. We're really excited to have our spring webinar here for the Michigan Cardiac Rehab Network. And we'll get things kicked off here. Oh, there we go. Here are our disclosures. Just a couple of quick housekeeping things. This session is being recorded. Slides from today will be shared with attendees, so don't feel like you need to take any notes. We'll be sure to circulate all these around. Please, if you have questions at any time during the session today, be sure to add them into the chat. There will also be time kind of baked into each of the presentations if you want to ask specific questions following both of our speakers. But if you have questions throughout, be sure to answer or put those in the chat. And if we don't get to them today, we'll be sure to reach out afterwards. And your participation today and feedback afterwards is really essential. It helps us to figure out what kind of content we want to keep providing you all with. So, don't be shy. Send us notes, put something in the chat, send us an email. We're always happy to hear people's thoughts on how we can continue to make this worthwhile experience. So today's agenda, we'll do a quick welcome with some quick MiCR updates. We're fortunate to have Dr. Alexis Beatty here to talk about kind of new frontiers for cardiac rehab. We have Brett Reynolds, who's the supervisor of cardiology at Corewell Health East, talking about some of the work that they're doing around heart failure. This is one of our mini grant spotlights, so we're excited to hear some of the work that he's been doing. And then we have some closing notes at the end. So some quick updates. There's a few small changes. I shouldn't say small. Some changes to our MiCR team that we're excited about. So as you all know, with Dr. Devraj Sukal's departure from the in-person meeting, we're really excited to welcome Dr. Jessie Golbus here, who is now the co-director of MiCR along with me. Dr. Golbus presented at our in-person meeting. She's got a lot of really great work around mobile health and involved in cardiac rehab at University of Michigan. So we're really excited to have her join our leadership team. And she will be helping to run today's session. Also, Jana Stewart, who has been a long time leader and contributor of MiCR, is going to be getting a more leadership role within the Michigan Value Collaborative. And so she'll be taking on some other initiatives within MVC, but will still kind of remain somewhat participating in the MiCR work moving forward. But we now have some additional contributors to the MiCR work from both BMC2 and MVC. Elizabeth Horn, Emily Blair, and Julia Manti are all going to be taking on some larger parts of our coordinating activities. So we're really excited to have their participation and effort. Also, MiCR and HBOM, the Healthy Behavior Optimization for Michigan group, who created all those really nice greeting cards and materials for us. We received a grant from the Frankel Cardiovascular Center at University of Michigan to do a patient story project. So we're going to be communicating more about that in the coming months, but we're really excited to receive a little bit of funding to help kind of further our efforts here in Michigan. We're going to talk very briefly about this, but there's going to be more in the coming months on this. We're revising and updating our strategic goals that the MiCR network has set out. We started with trying to get utilization or enrollment to 40% for all these eligible conditions within the state of Michigan. We're going to keep working towards that. We also want to keep trying to increase utilization of cardiac rehab to 10% for our heart failure patients. We're continuing to work towards that as well. Those are going to continue to be strategic goals for MiCR. But some new kind of strategic goals that we're really excited to pursue. One is to kind of support exploration and implementation of telehealth or virtual-based cardiac rehab in many different ways. Also looking into how we can support cardiac rehab medication management adherence. This is something that we're really excited to look into and help support through our collaborative efforts and our data. There's also going to be some new opportunities to collaborate with MiCR for those that are interested. We're going to be renewing our advisory committee membership. So Dr. Golbus is going to talk about that towards the end. But for those that want to get more involved in providing feedback and strategic direction to MiCR, we're happy to have those involved. And there's going to be some more details at the end for that. Again, we're going to be partnering with HBOM on these patient stories projects, so there's going to be more to come there. And also, we're trying to expand our website offerings for patients and providers through our MiCR website page. So more to come on that. There's new opportunities for those that want to get more involved in some of the work that we're doing. So to provide some updates, as I said, we have strived to increase cardiac rehab participation to 40% for our patients with AMI, CABG, PCI, SAVR, and TAVR. We look at our yearly trends from this quite often. As you can see, back in 2020, when we made this goal, our statewide average was just under 25%, and we had the goal of 40%. Looking at our most recent data, we're up to just about 35, just over 35%. So we've increased by 10 percentage points over the last 4 or 5 years, which we're really happy about. We're still a little short of that 40% goal, but I think given how the work that we've been doing and the trends that we're on, we're really excited to keep pushing towards that. Then looking at our heart failure goals, again, we started at just about 2% of patients in Michigan attending cardiac rehab. We're up to about 4. It's been pretty stagnant over the past few years, but I think some of the efforts we're trying to get around medication adherence and understanding and spending a little more time in the heart failure space, which Dr. Golbus is very much an expert in. We're really excited to have her participation to help us try to remove some of those barriers for these patients. So we're going to keep pushing on this and hopefully, make some improvements over the coming years. Okay, so without further ado, we're going to transition to our first speaker. But before we do that, I think we wanted to get a sense of where folks are at with cardiac rehab, virtual cardiac rehab, telehealth-based cardiac rehab. So we have a quick poll. I think Mary's going to bring that up here. And we'd love to get people's thoughts on this, which is, what best describes the status of telehealth, the virtual or remote cardiac rehab at your organization. There's a menu of options here. So if you wouldn't mind providing some of your thoughts on this, we'd love to hear where people are at. I think this will really help us to figure out how we can best serve some of the implementation efforts here in Michigan and understand some of the barriers and facilitators that people are experiencing locally. So if you wouldn't mind answering that poll question, we'll give people just a minute here to answer that. We'll see where we're at. Mary, whenever we see the poll questions have started to slow down, we can end it here. Okay, so looks like just only a few folks have fully developed cardiac rehab programs. Some have limited or pilot versions, some are exploring, but the large portion are not currently offered with no immediate plans, which I think is kind of what we've heard in speaking individually with folks. So, and even a large portion are not sure or not applicable to my role. So, amongst those that are kind of aware, I think most are not offering or no immediate plans to. So I think that puts us in a really good position to learn a little bit more about where we can go, and hopefully we can learn a little bit more from our colleagues across the state and nationally. So thank you for filling that out, and we'll be sure to take that information down. All right. Well, with that, I think this will offer a really nice transition to our first speaker. So Dr. Alexis Beatty is here to join us. We're really excited to have her all the way from the West Coast. Dr. Beatty is a co-director of the UCSF Cardiac Rehab and Wellness Center. She's a cardiologist and researcher at UCSF. She specializes in innovative care models for cardiovascular disease, focusing a lot on digital health and cardiac rehab. So she's helped to develop the VA Fit Heart, a mobile app for cardiac rehab participation. Previously, she contributed to Apple's heart-related features, and she's the program director again at the Wellness Center, Cardiac Rehab and Wellness Center at UCSF. So we're really happy to hear what Dr. Beatty's doing and how some of the stuff and work that she's doing could be translated here in Michigan. So Alexis, thanks for joining us, and we're really excited to hear your presentation today.
Thanks. I appreciate the invitation to speak with this group from Michigan, and hopefully I can help to get some of those people who are thinking about it or working on building their telehealth program to take a few additional steps to help build a telehealth program at your site. All right. And we're kind of looking at, this is based on national data, although it sounds like Michigan has maybe made some efforts to get this, 29% up a little bit, maybe more to the 35%, where we have people who are eligible for cardiac rehab, we refer them, they come mostly to in-person cardiac rehab, but we're not really getting all of the people in there. And I fully understand, setting an achievable goal of 40%. But if we're talking about million hearts goals, we'd like to get up to 70% or so that are enrolling in cardiac rehab. But what is the magic that will help us get there? And I think at least in my opinion, there is no magic. It's just going to take a lot of hard work and a lot of different tools to help us get to higher percentages of people participating in cardiac rehab. And so some of the stuff is work that you all have been doing in Michigan on improving the referral and enrollment process and helping patients navigate through that. But some of it's going to be in offering different ways for people to participate in cardiac rehab. And one of the strategies that we have, is what we used to call home-based cardiac rehab, and a lot of times we still do call it home-based cardiac rehab. And it's similar components to traditional cardiac rehab. So it still sort of follows all of the cardiac rehab core components. Well, the thing that's different, though, is that you don't have direct supervision of exercise in the center. And most studies have shown that it has similar safety and efficacy as traditional cardiac rehab. But when we wrote this scientific statement in 2019, we did feel like more evidence was needed in diverse populations and about long-term outcomes about home-based cardiac rehab. And evidence has been building since we published this scientific statement that continues to suggest that home-based cardiac rehab and telehealth approaches have similar safety and efficacy to traditional cardiac rehab. So one of the better studies that's looked at sort of remote digital cardiac rehab, so sort of using apps and mobile technology to help with delivering cardiac rehab, was published in 2014. And this was a group in Australia, and they were comparing traditional cardiac rehab to home cardiac rehab with a smartphone app. And they showed that the people participating in the digital cardiac rehab arm had improved participation, improved adherence, and were more likely to complete the program. And also still had similar improvements in exercise capacity, risk factor management, and quality of life. And over time, people have been talking about this in different ways and exploring some evolving models and terminology. Our traditional in-person cardiac rehab, is a synchronous exercise experience and occurs in person. There are also models similar to like what the group at Henry Ford is doing, where you have synchronous exercise and it's a video visit. And so it's synchronous exercise with a virtual visit. There are also models where people are exercising asynchronously and submitting their data via apps, kind of in a remote patient monitoring type of model. And we often refer to that as asynchronous or remote. And I think all of these modalities will be part of the future of cardiac rehab. And I've begun to think of it more as a continuum than as, purely home-based or purely center-based cardiac rehab. Because with cardiac rehab, we already do a lot of individualization of what we do for these patients. They come in, they get a thorough assessment, and we create an individualized treatment plan. And I think that individualized treatment plan can also include, what is the modality that's the right modality for this patient. And so, there are some patients who will be fully on the center-based in-person side. They need to come into the center and get that in-person attention. But there's a lot of patients that we see that coming into the center isn't really feasible for them, or they need more help figuring out how are they going to do this after they leave the center? How are they going to exercise and keep up these healthy behaviors after they leave the center? And so people like that are going to be more on this virtual remote sessions end of the continuum. And I think increasingly we'll see people doing hybrid models where they do some combination of in-person sessions and some combination of virtual or remote sessions. And so, as I was saying, cardiac rehab is already an individually tailored program, but I think that we can also tailor the delivery mode to the individual. So I'll share a little bit about our experience with UCSF. We started doing telehealth approaches to delivering cardiac rehab during the pandemic, as a lot of people did. But we've kept up our program going even after the end of the pandemic because we have a teeny tiny cardiac rehab center that only has 8 machines, and we get about 900 referrals per year, and we can only see about a third of them. And so we have to have a way to manage to see and deliver cardiac rehab to more patients. And so we've kept up with virtual and hybrid cardiac rehab so that we can see the volume of patients that we get referred to. And we're still falling short, but we're doing better than we would if we only had in-person available to us. So, with in-person cardiac rehab, it's a multidisciplinary intervention. People get education, health behavior counseling. Our patients come in for 32 center exercise sessions, and the balance of sessions are with our multidisciplinary team. And we do include supervised exercise in those sessions, but also are encouraging people to exercise on their own in between the cardiac rehab sessions. And then I'll draw your attention over to the right side to the virtual sessions. This has a lot of the same features as our in-person program. It's multidisciplinary. People still get health education and health behavior counseling. We still do intake and completion metrics with these patients. They still have ITPs. And then the core, though, of this intervention are 12 weekly phone, or it's almost always for us video sessions with people. And we actually do supervised exercise with people during those weekly calls as well. And then people in the virtual can come into the center. So we started out with requiring everybody in the virtual group to come in for a couple of sessions, but we've moved away from that, and we now no longer require them to come in for a couple of center-based sessions if they're in the fully virtual group. And then we do have a lot of people who choose hybrid. They want to get comfortable exercising. They want to make sure it's safe. They want to learn a few tricks from our excellent exercise physiologists. And so a lot of times these people will come in for about 10 center-based visits. So they come in for, a little under a month. And then we move them on to the home-based program. And so they get some coaching over video visits once a week to help them transition into their long-term plan for what they're going to do out in the world after they leave us. And we measured our initial experience. This is data just from the first year of our experience with delivering virtual and hybrid cardiac rehab. It was during COVID, so we did have a lot of sort of COVID-related dropouts, but we definitely had better completion in our hybrid and virtual models compared to in-person. When we looked at our outcomes, including change in 6-minute walk distance, on the y-axis here, you'll see improvement in 6-minute walk distance between the start and end of the program. And on the x-axis, you'll see the different groups, in-person, hybrid, and virtual. And we saw very similar improvement in 6-minute walk distance across all of the groups. And so over time, what we've done is we've kind of taken a lot of the things that we've learned about in delivering virtual and hybrid cardiac rehab, and we've created what we call the new delivery model toolkit. And this is posted online, so you can go and look at it. And it has a lot of scripts. It has a technology tool assessment if you want to look into what should a mobile app for cardiac rehab do. We have mobile app training templates. And then with this new delivery model toolkit, we've taken it a step farther, And we're conducting a PCORI-funded study that's called the MiCR study that's testing the comparative effectiveness of in-person and telehealth cardiac rehab. And so the first aim of this study was to tailor a telehealth cardiac rehab program to diverse populations at multiple sites. And so we went through and did human-centered design with cardiac rehab patients at multiple different sites across the country. And we're really happy to have Jesse and University of Michigan be one of our sites. And so they participated in this tailoring of this cardiac rehab program. And so if you go to that website, the toolkit website, you'll be able to see now that in addition to the templates that we have for the various scripts and materials, you can also see that there's now some variations. And those are examples of the variations that people at different sites through this human-centered design process made. And so one example that I'll give you is that the folks in Michigan, they were a little bit more concerned about safety than some of the other participants. And so Jesse and the team and the patients in Michigan helped develop sort of a beefed up home exercise plan plus safety plan for patients. And so if you go to the toolkit website, you can see the variations that were made on that. But we're finding actually that not a whole lot of variations need to be made for a lot of the materials. And so sites are able to take a lot of these materials and use them to help build their telehealth cardiac rehab program. And then after we did that tailoring of the materials, we're now fully into our aim 2 here, where we're doing a randomized trial that's randomized at the individual participant level. And people are being randomized to in-person cardiac rehab or telehealth cardiac rehab. Within the telehealth cardiac rehab arm, participants are allowed to have up to 12 in-person visits. And so it's really more of a telehealth/hybrid cardiac rehab program. And we believe that this will help decision makers, including a lot of the people on this webinar, to decide, is there enough evidence for us to set up a program like this? What types of patients benefit most from being able to do a different type of cardiac rehab. And then we'll also be doing an evaluation to understand some of the factors that influence implementation of these sorts of programs. And so, if you think about where this is, what are we really comparing on this continuum of cardiac rehab? We're kind of comparing this center-based in person to the more virtual remote end of things. One other piece that I do want to bring up, because you may have even been approached by some of these companies about offering virtual cardiac rehab as a service. And I think that this will increasingly be available and be an option that people may have. There are now companies that offer virtual cardiac rehab as a service. Most of these people will do their pre and post metrics with remote assessments. And so it's usually not a 6-minute walk test. It's usually something, like a quicker exercise capacity test. They do have cardiac rehab staff, usually exercise physiologists, delivering cardiac rehab with synchronous exercise with two-way audiovisual communication. It's virtually supervised by an MD medical director, often somebody who is licensed in multiple states, so that they can provide care across borders. And then it's variable what sort of technology and exercise equipment they provide. Some people do provide like pedalers. Some people provide, heart rate monitors. It varies very much from company to company what their sort of technology package looks like. And you can actually refer people to these external cardiac rehab programs now. And so, for some patients, this might be the right thing. You can refer when hospital-based cardiac rehab is not available. You can refer, in our situation, for patients who don't want to be on the wait list for our cardiac rehab program, or for patients who do not have accessible options. And some of these services are covered by private insurance, although they're not currently reimbursed by Medicare at a level that makes it makes it feasible. But a lot of private insurances will actually reimburse these virtual cardiac rehab programs now. And so, if we think about this present state and future state, I think that we can get to a place where we get more people enrolling in cardiac rehab, but I think it's going to take a lot of these different strategies to help get us there. And so I really applaud a lot of the work that you all are doing in Michigan. I think you've done great work on sort of automatic referral, navigation, creating materials to help, patients, get into cardiac rehab. And then I think it's going to be expanding some of these options for how to participate in cardiac rehab, whether it's in-person, hybrid, virtual, delivered by your hospital or virtual delivered by a third party. But I think that with all these various strategies, we have a more optimistic outlook for getting to higher participation in cardiac rehab. This is just to acknowledge that I work with a lot of people that help make a lot of the projects that we do possible, and to thank them for their efforts. And I think we do have a little bit of time for questions, so I'm happy to take any questions that folks may have.
Great, thanks. It looks like we do have one question, or a question or comment. Jackie, do you want to talk a little bit about this?
I really like the toolkit. I used the link, so thank you. That's a great resource, and your presentation's pretty straightforward. So just looking to hear more. And I do have a reimbursement update just from the AACVPR. Molly Corbett said there was an extension on the March deadline, so they pushed it down the line for telehealth services until September. So just got that off the press and thought people would like to know.
Yeah, and there is actually a bill before Congress as well that would make telehealth flexibilities available. Right now, the telehealth flexibilities are only available for physician fee service schedule programs, which is the minority of programs. The hospital outpatient programs, the only thing that you have is like the virtual supervision is allowed. But you can't actually get it reimbursed through Medicare right now. But there is a bill that would allow it to be reimbursed like long term. And so if people are interested, you can, on the AACVPR website, they also have the link for the sort of take action to write your Congress people to let them know that you want them to co-sponsor that bill.
Yep, excellent. Thank you very much.
Alexis, is there one piece of advice that you would give people that might be considering a telehealth program but have been kind of hesitant? And I know lots of people have different barriers, but having, you've gone through this now in the last 5 years with starting your program, and if there was kind of one piece of advice to people that were on the fence, what would you tell them?
Yeah, I guess maybe a couple pieces of advice. I think one, talk to people who've done it, and in Michigan, that includes, Jesse and the group at University of Michigan, who now has some experience doing this. That includes the group at Henry Ford, who has been doing this for a long time. So you can talk to these folks and learn from their experience to help you set up your program, so you don't have to do it alone. And then the second thing is, I think we all kind of love in-person cardiac rehab. Like, we know it's great and it works and our patients love it and we see the benefits to them. But I think and so I think we like it. It feels good. Our exercise physiologist who worked with our program, when we initially started doing this during COVID, he was like very resistant. And he's like, I just don't know if it's going to work. Like, I like being able to see the people there exercising and getting their blood pressures and seeing what their heart rates are. But he started doing the telehealth program and started working with patients doing telehealth. And in some of our sort of like interviews and qualitative research that we've done with him, he says now, he's like, well, like it's actually like very much the same, in terms of what we're doing with patients and what we're able to do and see with them. He's like, and I don't have the information right there in terms of like their, what's going on with them minute to minute while they're exercising. But other than that, it's like basically the same. And so now this exercise physiologist who was initially a little resistant about doing the hybrid or telehealth program, he only does telehealth now. And so that's what he spends his whole day doing. And he sees great results in the patients in terms of being able to individualize their exercise programs and help them find things that work, in their actual home environments. So part of it's just give it a try.
Thanks. Well, I think we're up on time, but thank you so much, Alexis. We've been working together now for a number of years, and every time I talk to you about cardiac rehab, I learn something. So really appreciate you being with us. And I also just wanted to take a minute to highlight Sam Fink and Joe Bryant that I know are here, and they're really the people that have been doing the work on developing a telehealth cardiac rehab program here at Michigan. And so thanks to them, but also they are the people to ask the questions because they are the ones that are really in it. So I just want to highlight them and thank them as a resource. So with that, I'm so pleased to be able to introduce Brett Reynolds here. So Brett is the supervisor of cardiology at Corewell Health East, overseeing cardiac rehabilitation services at the Farmington Hills, Southfield, and Troy locations. With a background in clinical exercise physiology and a master of public health, Brett brings a strong focus on evidence-based practice, patient-centered care, and team leadership. His team was recently awarded a MiCR cardiac rehab utilization mini grant to support their project, The Weight of Heart Failure. And he's here today as our This Is How We Do It presenter, and he's going to share with us the quality improvement work and lessons learned from this effort. So thanks so much, Brett.
Thank you for having me. And thank you again for the honor, giving Farmington Hills Cardiac Rehab this grant. But we will go ahead and get started. So just want to get started with our kind of Corewell Health's mission, vision, and values. So, our mission is to improve health, instill humanity, and inspire hope. Our vision is a future where health is simple, affordable, equitable, and exceptional. And kind of our values is compassion, collaboration, clarity, curiosity, and courage, which I think we all instill with our cardiac rehabs. But who are we? Corewell Farmington Hills, it opened up in 1965 as a 200-bed facility. It's since grown to a 305-bed teaching facility. Many of you may know throughout the state, it's formerly known as Botsford Hospital over here. We serve the greater Detroit metro area. Our procedure volume, we do roughly around 1,500 PCIs a year. And last year, our team, we did round on 472 inpatients with a diagnosis of CHF or AMI, kind of similar to, a lot of our phase 1 programs that many of our sites have. So as you can see, we're kind of sandwiched in over here in Eastern Michigan, close to our Troy and our Royal Oak hospitals. So for our site and our patient profile, we are a smaller facility. We have 6 interventional cardiologists. We don't do any open heart procedures here, so we do not have any cardiovascular surgeons on staff. If any patients need further care, they're typically transported to Royal Oak or Troy or something like that. We have 6 residents and fellows. We have 9 case managers, 6 APPs. For our cardiac rehab, we have 2 exercise physiologists and 2 nurses that work within our department. So our quality improvement team here, we have our kind of our key quality initiative players. The first one here is our stress testing nurses, specifically Laura. She's our individual that does a lot of, if not all of our patient routing and education. So she makes time throughout her day to get our heart failure cart, which is filled with a bunch of heart failure and AMI education, our weight scales, water bottles that have measurements on the side of it, and she goes out and sees our patients. Um, and then we have our cardiac rehab staff, Kelly, one of our nurses, and Sarah, one of our exercise physiologists. They're doing a lot of the follow-up phone calls and cardiac rehab scheduling. They were, I believe, on this spring webinar last year, presenting on it as well. So we have some really great staff here. Another one was our Epic analyst, Stacy. So her and I spent a lot of time with developing a new Epic report for us to really track down these inpatients that have heart failure as a diagnosis. And then this quality initiative is also kind of spired into a readmission committee for the hospital, including some of our physicians, staff physicians, EC physicians, with the overall goal of kind of reducing heart failure readmissions, getting more individuals into cardiac rehab. So it's kind of has spidered into that. And it's also kind of made us aware of some other issues that we're having specifically for our referrals. So prior to our quality initiative for the weight of heart failure, we were, rounding on our inpatients that have heart failure, AMI, but we weren't necessarily providing any follow-up or connecting them with cardiac rehab. But we would provide them with education, weight scales, those types of things. We were using a report that was going to be archived at the end of the year, so that's where we kind of stepped in and had a new report created. And then also the hospital was noticing our readmission rate for our heart failure patients and our cardiac rehab admissions were kind of slowly trending down compared to what they had been previously. Our kind of GPA for the heart failure readmissions last year was 3 out of 5. The previous year was 4 out of 5, so it did lower. So that's one of the reasons it's a key metric for us to look at. So for the current state, the weight of heart failure. So with this quality initiative grant, we're able to afford and purchase 100 Corewell Health branded scales for patient use. A lot of times, too, with a lot of the heart failure patients we're seeing, they may be in for an exacerbation, but they may not qualify for cardiac rehab based off their ejection fraction. So this helps kind of afford us the opportunity to provide them cardiac rehab with our cardiac fitness program that we have here. It is a self-paid option. However, it does give them a whole month of cardiac rehab use. The first week is 3 sessions that are on the monitor. We get to see what their heart rhythm's doing, what their heart rate's doing. And then the following 3 weeks are more or less of a maintenance program, kind of like a phase 3 program. But it awards us to reach 20 patients that could really use the extra care that may not qualify underneath their insurance. It helped us create a new heart failure report. And now, with that extra aspect of including more team members, we're making follow-up phone calls. So 2 weeks after we see them in the hospital, we call them. We want to know, are you weighing yourselves daily? Have you met with your doctor? You have a doctor's appointment scheduled. And then that opens the door for us to discuss cardiac rehab. Are you interested in doing cardiac rehab? We take a deeper dive into their diagnoses, see what they're eligible for. A lot of these calls are made by Kelly and Sarah, our nurses and our exercise physiologists. But as you can see, our goals at the bottom again is to kind of really dive into the patients, and the patients really are receptive to this. They like to talk. They like to let us know about what their experience was in the hospital and how they're doing. So it's been really beneficial. They've really enjoyed the follow-up phone calls, regardless if they end up coming to cardiac rehab or not, but they really enjoy it. So here are some of the tools that we are able to provide based off the quality initiative, and then also kind of what we're tracking. So we're tracking the date we saw them, if they got a cardiac rehab referral, their 2-week follow-up phone call. Are they tracking their weight? Do they have a follow-up visit scheduled? What their ejection fraction is. what date we scheduled them for cardiac rehab orientation or their cardiac fitness program orientation. And then also 1 month after they've completed either of those two programs, we're giving them a call again. Are you continuing to weigh yourself? Are you continuing to exercise? Just more and more follow up to keep them on the same and right path. So this is kind of a little snapshot of our data collection and how we kind of store it and document. It's ever growing as we round in patients every day, but just wanted to give a little snippet of what we're looking at. So to date, this number's grown, but we've rounded on 156 patients for heart failure. Our staff have made 110 phone calls to follow up with patients. We have seen about 65% of the patients called are utilizing their weight scales to weigh themselves daily. 83% of the patients called have made follow-up appointments. 3 patients are scheduled for a phase 2 cardiac rehab. That caveat too is many of these patients, depending on their insurance, whether it's Medicare, Medicaid, and the different federal and state guidelines, we do typically have that 6-week kind of waiting period before they can start rehab based off their most recent exacerbation or procedure. So that's kind of limiting us there. And we also have 3 patients enrolled into our CFP program with another 2 scheduled. So in total right now, we've helped increase about 22 total patients that are interested in our program for heart failure. And as you guys know, and as we discussed earlier, the heart failure utilization for cardiac rehab is so low that we're trying to really make an impact on that here and everywhere. So some kind of barriers and challenges is, the patients are really interested while they're in the hospital when we're rounding on them. Again, they're in the hospital, they're not feeling well, they're interested in cardiac rehab. But once we give them a call, they're not necessarily that interested at that point. They're at home, they're feeling a little bit better. So we're really trying to educate them and their physicians. That kind of 6-week wait period I was mentioning kind of also draws a delay where we see them so early while they're in the hospital, then we got to kind of put the brakes on for a little while and wait till they can get into the program. That can kind of discourage some patients. We have noticed, which is this quality initiative has helped us kind of put in the limelight there, is we're having issues with some of our orders. We do utilize an automatic referral system, which is very tried and true for all of our, cath patients, our surgical patients, and the interventionals. Right when that procedure is done, whether they're coming out of the cath lab or coming out of the OR, there's an order automatically placed. But for heart failure, that's a little bit of a different story. So we've been having some issues with access to certain physicians having access to our cardiac rehab referral. So that's something that we're really working on, is getting them access to the appropriate referral that's tracking to our appropriate work queues so we can make sure we're not missing any patients. And that stems into the next one too. Just overall, there's a lack of heart failure patients being referred to the program. Us doing this rounding, we're able to catch a lot of the patients who are eligible for cardiac rehab and go ahead and get an order placed or fax one to their physician. But we are really taking steps forward to getting this more readily available. And then also, as many of you guys know as well, but the physicians aren't really educating the patients in cardiac rehab when they have a heart failure diagnosis. It's not something that's always brought up. And as we know, the greatest referral, other than a physician putting in an order, is them actually discussing cardiac rehab with the patient. Myself or our nurses or EPs can give them a call and let them know, hey, your doctor referred you for cardiac rehab. But unless they really sat down and discussed that with them, it makes it a little bit more difficult job on our end. But what we've gone ahead and done is, with the new Beat material that we have, with our own material as well, we've been really providing those to the physicians, the floor physicians, the EC physicians here too, just to make them more readily available, and also for them to understand, what is cardiac rehab, who's eligible for it, so we can kind of hopefully capture all the patients. So to kind of wrap it up a little bit, for some lessons learned, is just to surround yourself with a great diverse team, include all necessary parties. many times in a healthcare system like this is brought up is that what we're doing was spidering off into what the hospital administration and leadership was doing as well, looking at readmission risk, looking at enrollment into cardiac rehab. So what we were doing was playing a factor into that, and it's helped open up the doors for our cardiac rehab team to really have 2 feet into more hospital leadership. And don't be afraid to ask for help. Everyone has their own niche. By asking for help, you can achieve your goals in a little bit timelier of a matter. Um, with that being said, we've included a lot more and pulled in a lot more hospital leadership and help within this grant and this quality initiative. And don't be afraid to educate your physicians. I think a lot of times too, some individuals or some places are more hesitant to really educate the physicians, or let them know they're making a mistake or that they're not putting in orders or those types of things. But we can really make a difference by not being afraid to educate them. Education's the best tool that we have, and by doing that, we'll see a better patient satisfaction and participation in cardiac rehab. And then I know I spoke a little quick, but if anyone has any questions.
Thanks, Brett. I have a question about the last point you made about educating your physician partners. Does it seem, I guess the question would be, um, is the education different for heart failure as compared to kind of the standard, qualifying conditions like PCI and whatnot? Do you feel that you have to, is education more important for heart failure and that because it's not kind of the traditional path,
I
that it
believe
may
so.
require a little bit more?
Yeah, I absolutely believe so. And, you know, a lot of physicians too, they're not aware of everything that we have to offer. So obviously we have our traditional phase 2 cardiac rehab that we can offer patients that have an ejection fraction of 35% or less, right? But we're seeing a lot of patients that have preserved ejection fractions, but that doesn't mean they cannot benefit from doing cardiac rehab to some extent. That's why we do have another program built for them. But a lot of physicians and staff aren't aware of that extra program that we have to offer them. So doing the extra step and letting them know that, hey, we have this extra um, program that we can help your patients with, and also that, I still think we just don't get enough referrals for heart failure. I don't think they think that there's no intervention going on, that maybe, there's nothing that needs to be done, where in all reality, some of the best improvements for an individual's ejection fraction or just their overall quality of life with managing symptoms is cardiac rehab. So I think we just have to do an extra step for heart failure.
Great. Thank you. Great work.
Thank you.
Okay, great. I just wanted to close today by talking a little bit about the MiCR Advisory Committee. And there will be more information that comes out from this over email, but we just wanted to remind everybody that we're going to be doing a renewal of our MiCR Advisory Committee. And this is intended to represent the perspectives of all of the stakeholders in cardiac rehab. And we really want to have as much representation from all of these individuals as possible. So clinicians, program staff, patients, and other cardiac rehab stakeholders. And so we're hoping that many of you would be interested in joining us. And really, this would be an opportunity to help influence MiCR strategic priorities and projects, to collaborate with leaders in cardiac rehab, contribute expertise to the development of new resources that we can then make available to others, elevate underrepresented voices and perspectives, and then help to advance quality and access to cardiac rehab services. Here we go. For those of you that are interested, certainly look for an email from us. There will be a kickoff meeting this summer focused on our upcoming strategic objectives. And then we anticipate that the advisory committee will meet about twice a year, predominantly virtually. All additional events for us. We're going to have our in-person meeting again this fall. And so please let us know if you or your site is interested in co-hosting this year. And then we'll have a survey also that's coming to gauge interest in participating in the Patient Story Project. Thank you again to our speakers, Alexis and Brett. This was really wonderful and just a pleasure. Thank you both for joining us today, and thanks to you all for coming this afternoon.